Greetings, PCLP scholars. I am Dr. David Norris, an Associate Professor of Family Medicine at the University of Mississippi Medical Center in Jackson, and it is my pleasure to introduce this 2014 Primary Care Leadership Program Colloquium entitled Exploring Diabetes. Along with hypertension, dyslipidemia, smoking, and obesity, diabetes is one of the major risk factors for coronary artery disease and is a leading cause of preventable blindness, renal failure, and limb amputations. Affecting nearly 26 million American adults, the costs associated with diabetes and its complications are estimated to rise above $3 billion over the next decade. And this number only represents the direct costs associated with treating the disease and complications. It does not include economic losses such as time off work and disability, nor does it include human factors such as stress and depression that are often associated with chronic diseases. The management of diabetes is particularly complicated, with primary care providers responsible not only for managing blood glucose values, but also providing and coordinating a plethora of preventive services such as foot and eye examinations and vaccinations. With patient encounter times averaging between 15 to 20 minutes each, physicians may become overwhelmed trying to ensure all recommendations are followed. And patients may become overwhelmed trying to understand their disease process as well as its treatment goals and techniques. The scholars presenting in this colloquium have developed a number of projects aimed at improving diabetes care by empowering patients through education, optimizing provider time utilization, and involving multidisciplinary team members. I would like to congratulate all of the scholars presenting on the quality of their work in such an important area of care for patients nationwide. And now, without further ado, we will begin our presentations.
The Diabetes Care Coordination Passbook was implemented in El Centro de Corazon, a clinic in Houston, Texas, to increase the self-awareness, self-management, and knowledge of the population of the East End community of Houston, Texas, concerning their diabetes in order to avoid the negative effects and complications of the disease. Self-management is a crucial component of diabetes care. Effective self-care can delay many of the detrimental side effects that come along with this chronic condition, such as eye, foot, and dental issues. Strategies to ensure diabetes treatment include proper diet, proper nutrition, physical activity, drug adherence, and annual checkups. This project identifies newly diagnosed diabetes patients and follows them through their care with the physician, diabetic counselor, and diabetic educator to determine whether a personal passbook given to them has an effect on patient awareness and outcome. The number of visits the patients actually bring their passbooks back will be measured, as well as whether patients have a better understanding of their own care. Also, whether or not the patient actually had improvement. The Patient Coordination Passbook allows patients to record things, including blood pressure, blood sugar, glucose levels, A1C levels, weight BMI, lipid levels, cholesterol levels, and a list of their current medications. A record of their annual visits and their diet and exercise goals are also there for easy reference. One of the major goals of the Patient Coordination Passbook at El Centro de Corazon is to have patients be their own number one advocate. The patients in the process should be more comfortable and effectively tracking their own diabetic changes, utilizing Patient Coordination Passbook, and ideally becoming more motivated to take control of their own health care and work to change their laboratory values. Taking a step into the future, talking to admin at El Centro de Corazon, the clinic will also look at providing incentives for those patients to actually bring their passbooks on a consistent basis. Hopefully, this will be further motivation to continue use. I have been talking with Dr. Young on about a weekly basis to find out how the patient passbook is doing. So far, patients are still bringing them back, but it's still not enough data to actually make any concrete conclusions. Treating diabetic patients in underserved communities can be a difficult process that can prove to be frustrating at times. Patients who lack the necessary resources find it difficult to keep appointments, be on top of their medications, and follow through with the recommended diet and exercise. But having a self-care approach should help these patients over time keep better track of the steps they should be taking to ensure that their diabetic goals are met. The lessons learned to date from implementation of this program are important for further growth in how we manage diabetic patients and get them excited about their own progress and understanding their values.
Hello, everyone. During my time working at Altamed Health Service Corporation this summer in Los Angeles, California, my independent service learning project focuses on evaluating a diabetic group visit pilot program that the diabetic health educators incorporated at Altamed earlier this year. The program was directed by 5 providers and run from February to April this year. There were a total of 3 sessions. Each session was about 2 hours long and about a month apart. The sessions were conducted in different locations in Los Angeles and Orange County. The objectives of the program were to increase patient knowledge on diabetes, evoke behavior changes, improve clinical outcome, and to a certain extent address costs by providing a financially sustainable program that can be replicated across the board. In order to evaluate the program, I look at pre and post lab markers. There were 7 primary endpoints that I look at, and the goal was to look for pre and post differences and examine the significance of those differences. I look at BMI, systolic and diastolic blood pressure, cholesterol, LDL, glucose, and hemoglobin A1c. In order to better assess patient and providers' point of view of the program and lifestyle changes due to involvement in the program, I distributed patient and provider surveys. The patient survey assessed patient general well-being since completing the program, assessed patients' mindset about the program, and lifestyle changes that patient incorporated in their lives since completing the program. The provider survey focuses on patients' compliance and involvement in their care, providers' comfort level with patients' ability to self-manage, and patients' involvement during and after the program. The quantitative data result shows a positive significant mean differences for systolic blood pressure, cholesterol, LDL, and hemoglobin A1c. The survey data show patients generally prefer this type of program. They agree that the program have positive effect on their life and management of their disease. General improvement in lifestyle changes and overall health were observed from both patients and providers' point of view. In conclusion, Diabetic Group Visit Pilot Program met most of its objectives. It increased patient knowledge on diabetes, evoked behavior changes, and improved most clinical outcome. The program should be continued with recommendation to implement better guidelines for future sessions.
Hello, my name is Monica Buckner, and my research project is Advancing Primary Care Through Dermatological Screening. Diabetes mellitus type 2 has been shown to increase healthcare delivery costs while negatively impacting patient quality of life. I believe the healthcare system can benefit from effective screening with the addition of counseling with evidence-based recommendations during outpatient visits. To investigate this belief, I sought to create a valid test that can be incorporated into clinic visits to maximize patient well-being and to strengthen the physician-patient relationship. First, I created a study that will focus on dermatological exam in relation to fingerstick glucose testing to identify acanthosis nigricans. Next, my population was selected randomly by attending community healthcare events for the underserved hosted by United Neighborhoods Health Services. Diabetes can be diagnosed based on 3 different criteria, 2 which this project will utilize. 1. A random glucose of greater than 200 with symptoms, or a blood sugar greater than 126 milligrams per deciliter with a confirmed second reading. According to this criterion, 20% of the sample population, N equals 25, was found to have diabetic blood glucose levels, 80% of which had acanthosis nigricans. I found 44% had pre-diabetic blood glucose levels, so I counseled on lifestyle modifications that can decrease their risk. Of the population, it was found that 11 of 25 participants had acanthosis nigricans with an average blood glucose of 124.82 milligrams per deciliter. Upon statistical analysis, there was a p of 0.1 3.4 that acanthosis nigricans occurs more with elevated blood glucose levels versus those with normal blood sugars. The p-value is not significant, but considering the small sample size, the study does demonstrate a strong positive correlation. Also, comparing a mean blood glucose of 124.82 milligrams per deciliter to the criterion using 126 milligrams per deciliter demonstrates that this dermatological scan can help identify those at risk for elevated blood glucose levels. While diabetic patients were given referral letters to direct follow-up testing with United Neighborhood Health Services physicians to establish a treatment plan.
My name is Elizabeth Carranza, and I'm a family nurse practitioner student from California State University, Los Angeles. My project was on diabetic health literacy in the Hispanic population located within Rochester, New York. My objectives were to assess and identify gaps in diabetic health literacy in the Hispanic population at Clinton Family Health Center. Additionally, my goal was to provide culturally appropriate resources addressing the knowledge deficits uncovered for clinicians to utilize as teaching tools during future patient visits. The methods I used utilized surveying both clinicians and patients. My clinician surveys were used to assess the challenges and knowledge deficits encountered when attempting to assist patients in achieving their goal hemoglobin A1C levels. As for the patients, a convenience sample including 16 type 2 diabetic patients between the ages of 39 and 79 years with hemoglobin A1C levels greater than 6% were surveyed. The key findings of my study reveal that many of the challenges cited by clinicians in getting patients to achieve their target hemoglobin A1C levels were due to a lack of easy-to-read resources in their native language, and also nutritional knowledge deficits present within this patient population with respect to portion sizes, meal planning, and being able to properly read a nutrition label. In surveying the patients, I found that 90% were able to successfully identify symptoms of hypoglycemia versus 63% being able to successfully identify symptoms of hyperglycemia. However, despite the high number that were able to successfully identify symptoms of hypo and hyperglycemia, many did not follow the standard protocol of checking their blood sugar levels upon the presentation of symptoms, and chose to immediately self-treat without checking blood glucose levels. Next, I found that 56% of patients were aware of the importance of continuing their diabetic medication regimen during sick days. And lastly, with respect to nutritional education, over 80% of patients were unable to accurately interpret a nutrition label, and only one patient could report the number of carbohydrates that should not be exceeded per meal. In summary, my recommendations are for clinicians to continue reinforcing symptoms of hypo and hyperglycemia with special emphasis on the treatment protocols for each altered state. Secondly, the biggest takeaway I found from my project was with respect to the profound importance of utilizing culturally sensitive visual images that offer size comparisons to emphasize appropriate portion sizes, as many of the patients presented with such low levels of literacy combined with visual handicaps. And lastly, I would recommend the introduction of the basics of how to read a nutrition label, along with a set guideline on the amount of carbohydrates that should not be exceeded, only if monthly nutritional classes are to be reestablished for patients. This concludes my presentation, and I would just like to take the time to thank all of the members of PCLP for this amazing opportunity and experience. Thank you.
Hello, my name is Nancy Castillo, and my clinical site was El Centro de Corazon in Houston, Texas. The title of my project is Insulin Perceptions of Adult Type 2 Diabetes Patients at Eastwood Health Center. The objective of my project was to identify perceived barriers of insulin use among adult type 2 diabetes patients at Eastwood and help providers guide their educational approach towards insulin around perceived barriers. In terms of methodology, I used a self-administered insulin perceptions questionnaire adapted from Diabetes Attitudes, Wishes, and Needs to determine attitudes towards insulin use among type 2 diabetes adult family medicine patients over a 3-week period. It was available in English and Spanish, and it was distributed by medical assistants and front desk clerks to the appropriate patients. Key findings from the quantitative data showed that Spanish speakers had higher insulin benefits perceptions and that English speakers more strongly agreed that the use of insulin could lead to worse health status. In addition, English speakers believed that insulin would make their lives less flexible, and this was statistically significant. Overall, there was a negative correlation between the perceived benefits of insulin to the fears and discomforts and others' perceptions. With respect to the qualitative data, Spanish speakers expressed concern regarding weight gain, fetal deformity, and the future need for dialysis with insulin use, and there was no qualitative data available for English speakers. Recommendations based on the findings from my study include addressing resistance to the use of insulin at the individual level. Education is very important, and healthcare providers should address misconceptions, concerns, and fears. Different education strategies may be beneficial, such as brochures or videos about insulin while patients are in the waiting area. It is also important to introduce insulin early on before the patient actually needs it, since it may be helpful in terms of explaining the benefits, understanding how it works, and developing a positive perception. Thank you.
My name is Velan Tat. I am a second-year physician assistant student at USC. My GE NMF PCLP site was in San Antonio, Texas. My project is titled Improving the Compliance of the Annual Foot Examination in Diabetic Patients. According to the American Diabetes Association guidelines, diabetic patients should receive an annual foot exam consisting of a monofilament sensory exam, a pedal pulses check, and a skin check. The annual diabetic foot exam helps prevent and mitigate the microvascular complications of diabetes, including peripheral neuropathy, ulcerations, and amputations. CMS and Medicare have incorporated the foot exam into a quality reporting measure and reimbursement rates. This project's objective was to determine compliance of the annual foot exam with all diabetic patients in a 9-month time frame through an observational chart review. I identified 12,651 diabetic patients with at least one patient encounter in the time frame. Of these patients, 935 patients have received the annual foot exam by referral to podiatrists. Of the remaining 11,716 patients that were not seen by podiatry, I randomly sampled 288 patient charts. For each diabetic patient sample, I analyzed the patient's chart for documentation of monofilament sensory exam, pedal pulses, and skin. For the 288 charts, I did not find any documentation of the diabetic foot exam by all the providers except a single podiatrist. Thus, the key finding was that only 7.4%, or 935 patients, out of a total of 12,651 patients had received their annual foot examination. I would expect that the annual compliance rate should be significantly higher. I propose will further utilize its podiatrists and, even more importantly, reinstitute the policy of having their nursing staff and medical assistants to improve their compliance with the diabetic foot examination to decrease morbidity and mortality for the diabetic patients. Thank you.